Bismillahirrahmanirrahim. Assalamu alaikum, respected audience. Today, my topic of discussion is about retinal breaks. This is a patient who presented to my clinic, a diabetic patient, 60 years old, and his vision was 20/20, both eyes, no history of flashes of light, no floaters. Just, it is a pure incidental finding that I found out a retinal tear, and you can see this one in the photograph, that this tear is right eye supratemporally located. So this is a magnified image of the last slide. Here you can see that this retinal tear has got a margin of whitening around it, which is shown in number 1, and this whitening may be because of the subretinal fluid or because of the vitreous traction at the margins of this tear. And number 2, which is shown, is a big operculum which is overhanging it. This patient has macula on, so his vision was good. Otherwise, apart from this, the retina was flat. The incidence of retinal breaks in general population is 2 to 9%. Posterior vitreous detachment is an important contributing factor in all these retinal detachments. 87.6% of all rhegmatogenous retinal detachments have posterior vitreous detachments, and out of these, half of patients have partial PVDs. So it is an important factor. It is because of the pull of the PVD, vitreous detachment, especially partial, that is a contributing factor. Once there is total PVD, there is no more pull on the retina and it is relatively safe. But whenever there is partial, there are high chances that there can be a break, there can be a traction, and it can lead to the retinal break and ultimately retinal detachment. Retinal breaks may be of different types. They may be atrophic retinal cones, they may be with or without operculum, flaps, they may be horseshoe-shaped tears, and they may be giant retinal tears with or without vitreous traction. So there are different types of the retinal breaks. In many circumstances, they are asymptomatic, they are not causing flashes, photopsias, decreased vision, detachments. They are asymptomatic breaks, which may be found in different degenerative conditions like degenerative retinoschisis, that is degeneration, and snail track degenerations are a few examples where we can have retinal breaks for years but not causing any effects. These are asymptomatic. If there is already retinal detachment in one eye, then the other eye, if it is pseudophakic, aphakic, myopic, or any trauma, these are considered predisposing factors for rhegmatogenous retinal detachment. So these patients have high chances of having these RDs if the other eye has already got a retinal detachment. Well, if we talk about the cumulative incidence of RD in asymptomatic retinal breaks, different studies have been conducted, and it has been shown to 6 to 13.8% in 6 months follow-up in those studies, which will I mention in the detail at the end. So it is considered that if one eye has got a retinal detachment and the other eye is having retinal breaks, and it is pseudophakic eye, so prophylactic laser of those retinal breaks should be considered. Symptomatic retinal breaks which are on and off, causing patients photopsias, flashes of light, and a patient comes to your clinic and says that sometimes he feels these flashes, lightning effect. So these are symptomatic, and the chances of developing retinal detachment in these patients are very high. The different studies which were conducted over a period of 10 years, they documented the incidence from 35 to 47% although this statistical and these results are debatable because of such a long period of duration. But even then, retinal breaks who are causing these symptoms, they should be properly protected by lasers, and they should be secured. They should not be left untreated. It was found that once laser was done, the chances of retinal detachments decreased substantially, and they decreased up till 2.1 to 8.8%. So the retinal breaks laser and their protection and their securing is very beneficial in treating these patients. Number two, it was found that even after doing lasers, these patients had the chances of developing the breaks, and it was 7.3 to 14% in different studies. Now we discuss about the prevalence of posterior vitreous detachment. As I discussed in detail earlier, that is the pull and attraction of this PVD, which is a very important contributing factor. So they conducted a studies, and they found that if there was no PVD and rhegmatogenous retinal detachment developed, 40% had retinal round holes. But if PVD developed and that led to retinal detachment, 98.5% of patients had horseshoe tears, and 1.5% had joint retinal tears. So if you are examining a patient and you find over there PVD, and along with this there is a retinal detachment, so very high chances of finding these types of breaks, that is horseshoe or joint retinal tears. So what is the treatment when these patients come to you? So these retinal breaks, if they have got a margin of subretinal fluid around it, they should be secured by 3 to 4 lines of lasers which are closely applied to each other, and these breaks are secured. Another way to treat them is by cryopexy. It is applied approximately 2 millimeter confluent cryoburns, and cryopexy is especially important for very anterior retinal breaks, which are difficult to be handled by indirect. And there's one more thing, that if a retinal break is surrounded by a margin of subretinal fluid, it is called laser barrage. But if the margins are dry, we call it retinopexy, laser retinopexy. So it is very important to properly evaluate these patients, secure these breaks, and I mentioned they have also tendency to develop later on, so close follow-up should be done, because especially this patient which I showed you, it was properly secured, the vision was 20/20, but if we do not follow up these patients and these breaks are unleft, and once the macula is involved, the prognosis and visual potential decreases substantially. So it is very important to regularly observe these patients and see all the quadrants, especially in the high risk groups. For example, those patients who have already got breaks and detachments in one eye, high myopic patients. So that is very important. These are the references. For example, that one, the first one is the prophylactic treatment of retinal breaks, a systematic review published in Acta Ophthalmologica. Most of the review literature was done from there. Apart from the statistical analysis which I discussed with you, taken from the different studies conducted different time periods, that have also been discussed in this reference list. I want to thank my respected audience for attending this lecture and for their attention. Thank you.